Hey, thank you so much, Dr. Malik, for that really fascinating talk. So now we'll have a joint Q&A and discussion together with both speakers. So I'd like to invite Dr. Kirk back up to the stage, and we'll just get set up here. And hi, Jitendra, can you see us? Or I'm not sure how this works.
Yes.
Okay, great. Okay, so I think, the audience can start thinking about any questions you have for either or both speakers. And I think this is also a great opportunity to have both a computer scientist and a surgeon here together. So you can also think of any questions for both of them. I'll start off with a couple. Maybe I'll start first with just a follow-up to what Dr. Malik just spoke about. So I think this is a really interesting talk with a lot of very impressive results. And I'm wondering, just going back to some of the potential clinical applications that you mentioned at the beginning, do you think that these methods are, sort of ready to work out of the box on these? I guess we haven't realized these applications yet in many cases in the clinical world, or do you think we need more data in these domains? That a small amount, a large amount, or are there additional kind of methodological challenges to be able to actually execute those applications that you mentioned?
In the context of machine learning, I always feel that there needs to be empirical work and tests done in the specific domain. So while I believe that the technique is totally general and it works, the standard data sets that we have, they don't have the kind of backgrounds that you might have inside an ICU room, right? So suppose I want to monitor there, I want it to be tested in those settings. But there's nothing about the techniques which imply that they should not work in all these kinds of settings. So, but I think the safe course is always do empirical tests in the as close to the use condition as possible. But I remember work from your previous work and with Feifei, which were on looking at whether people are sanitizing and things like that. Well, we need to have images of that kind of data and then just check.
Okay, great. Thank you, Dr. Malik. I think that actually maybe leads to a second question, which is also a question for Dr. Kirk, which is, I'm wondering if I can ask some of your thoughts on just data in healthcare. And Dr. Kirk, you mentioned sort of the importance of collecting more data moving forward, as well as prospectively collecting data. And I'm wondering, in many of these cases, I think still healthcare data can be hard to collect in some cases. It can also come at, let's say, smaller volumes than what we may be seeing now, let's say in maybe machine learning and more generally with very large language or vision models. Just the scale of some of these data is still quite different now. And in particular, so also the case that Dr. Malik, you mentioned with the, let's say ICU settings, and we've got, let's say, patients in bed or in kind of very different types of appearances. These data are not always as easy to collect. I'm wondering what you think in terms of, are we going to be able to get as much data as we want or we need in healthcare? How long will these things take? What do you imagine is in maybe 3 to 5 years the situation of healthcare data? Will we have enough for many of the problems that let's say that you had mentioned, Dr. Kirk, or what types of data paradigms will we have at that point? Maybe I'll ask Dr. Kirk first, and Dr. Malik too, if you want to add on afterwards.
Yeah, there's a lot to unpack in that question, but the capture of data that are reliable has to be integrated into the natural workflow of the clinician. Data capture that is an additional task or an additional click or is not really helping the physician care for the patient will always be increasingly inaccurate. If I need to, for example, capture a piece of information that is vital to my next maneuver, it'll be a pretty good data point. But if it is solely to facilitate billing, it will be less relevant. And if it is, in fact, just an administrative task, it will just be copied. Importance of data capture and integrating it into the vital workflow of clinicians, and to the extent possible, making it non-dependent on discretionary action. And that will start getting the size data sets and the amount of valid data that you need to make predictions. The one other thing I will say is that we're very focused, and I was struck by the wonderful talk that we just heard about the human as a isolated thing. But for example, if you add the element of sound to the data set and start capturing sound as it relates to the movement of the person, all of a sudden you have totally different predictive models. So for example, somebody dancing, if you have the music, you can better anticipate how they're going to move. Or if there's a gunshot that goes off in a crowd, all of a sudden that dramatically changes your predictions of where they're going. And for clinical data, it's the same way. If you're trying to analyze somebody doing a robotic operation and all of a sudden blood appears in the field, all your predictions before that happened are going to be very, very off. So capturing the environment as well as the individual is going to be quite important.
Thank you. And Dr. anything to add?
No, that's a wonderful answer to which I can add very little. My own additional observation would be that in addition to collecting data, we have the challenge of annotating the data. So I had a collaboration with colleagues at UCSF, which was on interpreting CT scans. And unlike most generic video data where we can get it annotated by anybody who can see, here the annotation had to be done by my colleague, who was an expert radiologist. And this makes this, of course, a very expensive and time-consuming process, but it was necessary. It could not be done by, workers on the internet. And what that meant was that new computer vision and machine learning techniques were needed to minimize that labor. So we used techniques like active learning to reduce the number of examples that my colleagues had to annotate.
Thank you. Okay, so at this point, I'd like to just open up to any questions from the audience. You can raise your hand and the mics will come around. I think we have one over there.
Hello. Hello, Dr. Kirk and Dr. Malik. Thank you for your talks. Dr. Kirk, my first question is, when you see Dr. Malik's presentation, which first use case does it inspire for you in the operating room?
Well, the use cases that are currently emerging are the ability to detect instruments in the operative field and detect their motion as it relates to structures within the operative field. The most common one that's being used right now is to detect what's called the critical view of safety. When you're taking a gallbladder out, there's a classic error. Whereas if you don't identify 3 structures, the chance of you injuring inadvertently the common bile duct is very high. It's the actually #1 injury that leads to lawsuits in the United States, which is why people are very interested in it, not because it hurts people. The ability to look at an instrument, have the computer look at an instrument and say, this is what that instrument is, and it's getting dangerously close to the structure you don't want injured, or to identify that critical view of safety, which has been associated with making the right decision in that space, is where a lot of this is happening. And I would envision, in fact, a lot of people are envisioning this now, it's not my idea, that your clip applier, the thing that you use to clip the gallbladder off to take it off, would not be activated until the computer saw the critical view of safety, unless you had a manual override. So the most errors occur when the surgeon doesn't identify those three structures and misidentifies one. And if the device that was allowed to cause the injury didn't work until it was satisfied that that view had been attained, that's going to be, probably make it harder for somebody to make an error, or at least make it much more explicit that they made an error than before. And so I think it's seeing interventionalists in their environment and trying to keep them out of trouble. That's the number one application that's probably out there right now.
Dr. Malik, are you saying something?
No, I was just going to say that that was a very interesting point, and I think it connects to some research which is going on in computer vision, which is on activity monitoring. So it might be, the typical examples for us are you're trying to cook some dish and you're following a recipe. And what we want is, let's say, a camera mounted on my glasses, or looking down on the cooking range. And what it should be doing is following along the recipe. So at every stage, identify what step we are in the recipe and what are the objects with which we should be interacting. So this is the stage where you chop the onions with a knife. Okay, so now you should be able to say, this is the knife, this is the onion. So essentially follow along a recipe in every stage. So that's a problem which is very far from being solved. I think it's a hard problem, but to me, it seems somewhat similar to what you talked about. To be able to do it effectively and with high accuracy would be amazing.
Yeah, those things are absolutely emerging in surgery, although it's not an onion with a knife, it's the aorta or something like that. So.
All right. My name's Dan Adler. I'm a PhD student at Cornell, working mainly in machine learning for mental and behavioral healthcare. Thank you both for your talks. My question for Dr. Kirk is, what has surprised you when implementing machine learning in healthcare applications compared to other therapeutics or devices or new techniques? And I guess the analog is, as a computer vision researcher for Dr. Malik, what's different about publishing research with healthcare applications compared to traditional computer vision research? Thank you both.
So the most surprising thing I've had is how resistant people are to adopting it. If I say, here's a new heart valve, it's the greatest thing ever, people will clamor to want to use it. If I say, this is an algorithm that tells you which heart valve to use, there's immediate resistance in its adoption. And that emotional resistance, very similar to the example that I used with the adoption of sterile technique in surgery. I mean, what could be more fundamental than that? It took 30 years for people to accept it, and still people don't wash their hands when they walk into a patient's room. So human adoption of logical next steps that's a tough one.
And Dr. Malik, I think the question to you was the difference between publishing in computer vision research versus computer vision for healthcare applications.
Yes, so I think some of these have been alluded to in the previous questions and comments, which is the availability of the right kinds of data. And I think, and the other is that to me, it seems that various computer vision applications, we always have to consider the trade-off for errors, for making errors, right? So we build a computer vision application for returning images from a Google search or YouTube. If you make a mistake, it's fine, right? It's just slightly annoying to have some, links show up which are not of use to you. But obviously, the cost of a mistake in the medical context or a clinical context is much greater. So I think that we need to, computer vision researchers need to quantify our results. So we cannot just assert something without putting error bars around our assertion. And I feel that this is an area of research that is quite important in classical statistics, but in the current deep learning era, it has been neglected. And we need to pay attention to that. So I feel that clinicians should pay more attention to us when we quantify our claims with error bars, because then they can, there's always going to be a risk-benefit analysis, but they can do that better if we provide those error bars as opposed to just saying, here's my answer, take it or leave it.
To add on to that, a very simple problem that we've been trying to tackle is just how long will an operation last? The surgeon has to predict that to schedule the case, to get time in the OR, and to figure out how many cases they can do in a day. It's fairly straightforward. And surgeons are always underestimating it. They think they can go faster than they can. And so we've been able to put together a machine learning model that is much more accurate than the surgeon, and have been able to show the data to the surgeon and say, this is more accurate than you are. This is 90% accurate and you're 50% accurate. But even with that data, the natural tendency of humans is to go, well, in general, people are 50% accurate, but I'm 100% accurate. And until we get to work with that fallacy, it's going to be a challenge. And that's a super simple problem, that you have objective data every day to show whether you were better or the machine was better. And even that is more challenging.
I think it's a very, very interesting example. I think there's a question in the back over here.
Thank you. This is for both of you, I guess, to answer together. But one of the primary use cases I've seen for the imaging in surgery, computer vision, is it's usually said as like trainee competency assessment as one of the early use cases for it. So how, in the development of these data sets and technologies, are we able to preserve the ability of differently abled trainees to show competence in the ways that on data sets that are trained by people without disabilities?
So some really good work is being done by Carla Pugh at Stanford in this. And the best way of distilling that down is in finding surrogates that associate with competency. If you're trying to watch someone move and determine if each motion is the right motion, that problem currently is insoluble. But if you associate competency with efficiency of motion, and then ask which person doing a procedure made fewer movements and had less variability in the range of their motion, which are the two characteristics that are what link with competency, then that's really how those things are coming out. So for example, if someone who has done an operation many times and is a recognized expert does it, instead of having hands all over here, the hands are actually not moving a whole lot. They make fewer motions, the motions are smaller, and they actually move slower around certain critical times of the operation and faster in others. Where as someone who's not an expert, the distribution of the speed of their motion will be randomly distributed across the operation. The error bars around what motions they make will be much greater in the erratic nature of the motion. So you're not really measuring their competence, you're measuring surrogates for competence, which are actually pretty easy to put objective metrics around.
So the one relevant computer vision work I can think of is on monitoring skills with respect to biomechanics. So imagine, for example, your golf swing, right? So you can have an expert look at it and give suggestions on what you need to do to improve it. But you can imagine a computer program looking at a video of you and comparing it with your swing with that of professionals who do a much better job. So I'm imagining that we should be able to have video of trainees and novices and experts forming the same kind of operation. And from that, the computer program can link to various features and provide sort of avenues for improvement. So I'm thinking of it as a teaching tool more than anything else. Again, it's not there yet, but I think there's a lot of interest in it for non-clinical activities as well. And I think we are working on problems of that type.
So
Thank you. I think we're close to the end of our time, and so maybe we can finish with one more question, which is next.
So my question's primarily for Dr. Malik, but to me, one of the most impressive juxtapositions of the two talks. So Dr. Kirk, during your talk, kind of going through the history of monstrous acts or barbarism and some of the history of surgery. And then Dr. Malik, you showed the image of a body being kind of assigned to a pose that you use the word monster as in terms of twisting joints. But to me, I look at that and I see injury. And I see Dr. Kirk ending his talk with really studying injury and how people respond to injury. And I think of the way that we're taught in medical school, where you start with physiology. And it seems like computer vision right now is starting with anything that's not injury. And then after you master physiology, you start with pathology and pathophysiology and mechanism of disease. So I'm curious, how do you see computer vision going from mastery of what is normal to start to account for some of the things that Dr. Kirk does in the OR and that his colleagues do in the OR that would probably be labeled as monstrous by any annotator?
Yeah, I mean, that's a wonderful question, and there's a lot to say there in humanistic terms, in terms of even the choice of our terminology. But as a computer vision person, I'm going to reduce it to the problem of we need data and we need examples. So unfortunately, our computer programs don't generalize as well as humans do. So what is not in the sphere of their experience, it will be called a monster. And that's and so the way to cope with that I know of is more about data,
Yeah.
which is a somewhat unsatisfactory answer, because obviously humans have causal models, so they can extrapolate much better than our computer programs can today.
Yeah, one of the biggest problems with assessing pathology is that normal physiology is generalizable. Pathology is ends of one. So when you are looking at an abdomen that has not been violated before, you can really get models to understand what the gallbladder and what's the stomach and where are you, and very straightforward. But those aren't the cases that are the problems, unless you're just not paying attention. But when you get into an abdomen that has had 4 operations before and is scarred in a very personal, individual way, there's not a training set for that, except for to say that this is not normal. And so sometimes just having someone on your shoulder going, oh, this is not normal, is a good thing to have. So maybe that'll help.
So yeah, very interesting answers. So I think we're at the end of our time, so we're going to need to stop. But I wonder if we can just end with one maybe concluding thought from each of you on maybe for Dr. Kirk, what you wish, something you'd like to, wish that computer scientists knew more that could help with interdisciplinary ML and health research, and then same thing, Dr. Malik, for clinicians.
Well, I mean, the one thing that I think we all have to get to is that computer scientists by themselves will not solve the problems, and clinicians by themselves will not solve the problems. We have to get into the same room, sharing our unique views on the problems at hand, both normal and abnormal, to work this out. And solutions require true multidisciplinary collaboration. And I think we're doing that pretty well in our institution, but we could always do better. I think as a society, we're not doing it particularly well. And I think that we really need to get clinicians and data scientists working, rowing the same boat, for sure.
Thank you. And Dr. Malik?
I couldn't agree with that more. I think the right spirit is collaboration, and I have from personal experience, I have found them very enjoyable and very learning experiences. And so I highly recommend working together with people who actually know the clinical end of the problem. And otherwise, as computer scientists, we may very often land up focusing on the wrong problem. And, so I think working jointly in interdisciplinary teams is the answer.
Okay, well, it sounds like at least Dr. Malik and Dr. Kirk are very much in agreement on this point. And so with that, I'd just like to give another round of applause to both of our speakers today. Thank you very much for the great talks and the great discussion.